Accepting me in the nose because it changed really my life.
The practice changed because of it, huh?
Practice. Yep. Yeah.
Yeah, that's a good thing. So you're glad you did it, right?
Yeah. I hope to come back again to Rogers, but
yeah.
when it's possible, because now it's really
yeah, it's not now. I get it. You know, you need to come for CN05. We'll do that again next year. That's an amazing course. You know, it's not really occlusion centric, but that's going to change your practice too when you get into the PRF and the ozone and the lasers.
I have to do first the 4-1.
Yeah, well, you can do that online, you know.
Mm-hmm. Yeah, I know.
Yeah, I mean, Marcelo and I probably won't do a CN04 this year because of the obvious reasons, but next year, Marcelo, you think we'll go next year?
I hope so.
Yeah, me too. Yeah, I wasn't counting on a CN03 or 4 in 2021, but 2022, I think we'll have one. So I don't know. We'll see. Again, welcome everybody. So I thought it would be a really good idea for some of us CNO people to put together something practical for the general dentist or the specialist that thinks that the TMJ stuff is not in their purview or in their wheelhouse. Well, the reality is it's in all of our wheelhouses, and we all need to be experts or at least have a working knowledge of this orthopedic component, which is basically 2/3 of the occlusion. And we have to recognize that. And Marcelo and I decided today to put something out there that was a little bit more on the basic practical level. And introductions have already been made, so I'm going to move on with the presentation. So again, I am the founder of the teaching network known as the Center for Neural Occlusion. And this is Marcelo and I back in December of 19, the last time we were physically together with my dog Cooper. And we were doing the premiere version of the CN04 TMJ pathology screening, which is on our website on cnotmj.com. It's available for streaming. That is the most intense course I've ever attended, and I was part of it. John Radke and Marcelo Matos blew my mind with the knowledge base. And, you know, they're opening my mind up to things such as nuclear medicine, blood work, all these things that dentists aren't really comfortable doing and interpreting, but not to mention the MRIs and the CTs, you know, that's low stress comparatively. But anyhow, so there was only a few of us there, but it was an amazing course. And there is John Radke, one of my mentors, with Marcelo in the lecture. But on to the present. I would like to advance here. There we go. So how patients find me over the years, because I have a global presence, so to speak. I see people from everywhere, primarily via YouTube. The YouTube channel, you know, we have about almost 11,000 subscribers, and a percentage of them are dental professionals, but most are patients, and they're looking for answers. And, you know, they'll travel to me from all over the planet pre-COVID because they can't find answers in their locales. I've literally seen them from every continent except for Antarctica. And that tells me something. It doesn't tell me that I'm that great at what I do. What it tells me is that I'm thinking outside the box and doing things that nobody else is doing. So there's a huge need for this here, this kind of information. So that's why I started the CNO years ago. And along the way, I started doing some research in my practice, which is very hard to do if you're a private practitioner. Some of the people on the Zoom call here were with me, Dr. Kirstein, John Radke, and others. And I want to thank them for that. And it opened my mind up to more of a research quantifiable angle, which my mind kind of wraps that way anyhow, but it reinforced the fact that, you know, you have to really know what you're talking about and be able to put numbers to things. Hence the CNO motto, which is measured matters. I've also participated in several chapters and textbooks, and that was quite the honor. And I've lectured, and these are just a few of the lectures over the years. The most recently was the Netherlands at the end of 2019, pre-COVID. And anyhow, the board of advisors for the CNO, as you can see, it's a plethora of different specialists and GPs in dental world, and Marcelo is one of those people, and it's a network. Okay, this is not a teaching center per se, it's more of a network. All of us put our minds together and try to advance the science and the art of what we do. So in the best way to put this is I'm trying to quantify with the CNO, occlusion, the orthopedics, diagnostics, and treatment of all kinds. In other words, we're not just limited to the TMJ and the bite. We are trying to hit novel topics that those of us in dentistry don't really see every day. We can't find in the mainstream teaching. So again, the motto for the CNO, measured matters. Proper diagnosis must always precede responsible treatment. That's the ethical way to go. It's the right thing to do. And how we do this is we put objective numbers to things. And most of all, we need to protect the patient. I need to treat everybody like I would myself and my family. Plain and simple. Quantifiable efficacy is what I'm looking for here. And I want to emphasize, lastly, we have a three-legged table in play when it comes to the occlusion. We have two joints and we have teeth. So it's like a three-legged table, joint, teeth. And if one of them is unstable or shorter than the other, for example, the entire system may become unstable. And oftentimes, excuse me, oftentimes the only way we can prove this is by imaging of the joints themselves via both hard and soft tissue metrics, not to mention the biometrics that companies like BioResearch have provided for us. They're very accurate. The bottom line is put a number to it and measure. So a quick intro, just a very fast introduction as to how the TMJs relate to the occlusion. Wait a minute. Apologies here. So the introduction. A third of the occlusion happens in the front that we're familiar with, and we're using a T-scan there, digital occlusal analysis technology, to track force and time. It's a very accurate and reproducible metric. We have a reproducible recording, and this is state of the art. This is something that I own 4 of these in my general practice. I use them just about on every patient. Anytime I'm altering occlusion, whether it be a composite filling or 3 fillings or 2 crowns or implants, you name it, I'm always getting a pre-op bite and I'm getting a post-op bite, entering it into the chart, and I'm able to track this. And this is part of what I've published on over the years. And then, of course, we have the 2/3 of the bite that no one's really looking at. 2/3 of the occlusion would be the orthopedic TMJs. And as I mentioned minutes ago, we have 2 joints and we have the way the teeth come together. And if we alter the joint itself, we can have a problem. Again, joint, teeth. And we'll demonstrate that here in a minute. But what's very relevant, and a lot of us aren't really aware of that, or this, and we haven't thought about this in school perhaps, but ligaments hold the soft tissue disc atop the condylar head, between the condylar head and the temporal fossa. And it acts like a buffer, like a pillow of sorts. And oftentimes the ligaments can get damaged. And if they do, the cartilage may tear forwards. And as we'll all remember from school and from practice, if we're looking at MRI, for example, the posterior band is the thickest part of the disc. If you're looking at a sagittal view, the intermediate is the thinnest, and the anterior band is intermediate in thickness. So if you displace the soft tissue disc because the ligaments get torn, it's like taking a crowbar to the hinge of a door and you can bend the door. The door would be the mandible. Hence, the mandible with teeth attached may hit the maxilla, which would be the jam with teeth attached, in a different way. And oftentimes that leads to sequelae that are negative. They may be wear patterns. There may be cold sensitivity issues. There might be chronic pain, headaches, things like that. And oftentimes we have to, get to the root of the problem. It may not just be the way the teeth come together. It might be the joints themselves. And the only way to truly vet the occlusion is to look at all 3/3 of the system, joint, teeth. All right, so this is an old video that I made many years ago from Dr. Mark Piper's anomalous medical software. If you'll notice, blue means teeth are touching, white means they're not. And as we tear the cartilage forwards, it will alter the occlusion. This is a very nice way to visualize that and burn that in our minds so we realize the relevance of what I'm talking about. All right, so forgive my computer because it's acting up on me. Hang on. It just froze. There we go. All right. Anterior guidance is biomechanically determined by what? We as dentists, of course, will answer teeth. A few of us will answer, well, the muscles have something to do with it. A very, very, very small percentage of us will start looking at this stuff. The shape, size, condition of the condylar head of both TMJs. Remember, that's 2/3 of the occlusion. The shape and condition of the articular eminence on both sides. Presence or lack of adhesions on the left and right side, intracapsular adhesions, scar tissue, and then the discs themselves, the condition, position, degree of herniation, as we saw in that previous quick video snippet from Anomalous Medical, I was just trying to demonstrate what soft tissue alterations can do to the occlusion. So all these are relevant. So if you really want to know what's going on, you need to understand what's going on with all three table legs. So I decided to put together a practical case study. I do something called CAD Smiles. CAD Smiles, I get together with a certified dental technician. I fly him in from California, and we do cases where we'll do like an entire set of veneers, start to finish the same day, using CEREC technology. I do usually 2 to 4 patients in a 2-day time frame. So that's anywhere from about 16 to 20 veneers a day, start to finish. Okay, so about a month ago, we did 3 patients that trip. And one of my patients, as you'll see in the case study that we're presenting here, presented with wear facets and all kinds of a weird problem with his occlusion. He wasn't symptomatic, but when you see the photos and the images, you'll understand. And I explained to him the relevance of the joints, the 3-legged table, and he went ahead and went through with what I call neural occlusion screening, hence Center for Neural Occlusion, right? Where I'm putting numbers to the kinesiology, the timing, the orthopedic condition, the status of the muscles, the position, condition, degree of herniation of the disc, etc. So we put him, now look at his smile, 31-year-old guy, nice guy, successful businessman locally. He owns coffee shops. They started with 1 3 years ago. They have about 12 in the area now. He's going to give Starbucks a run for the money over the next 10 years. And he can afford, but I'm not going to take his monies at $2,000 a veneer if I can't predict efficacy, if I can't predict predictability. All right, so look at his bite at 31. All right, so his history, football. His history, multiple traumas in football. He broke his front tooth playing football years ago when he was in high school, and that was the crown that they gave him. You can kind of tell that was done when he was pretty young, and he'll talk about it in the video that we'll see in a few minutes. But so this is an example of how I might vet clinically occlusal issues in my practice. Forget the TMD patient, forget the pain patient. I'm talking about the practical bread and butter, the stuff that generates revenue for me, my cosmetic end of my practice, which is a percentage of what I do, just like anything else. Okay, so this was a good example of demonstrating how, now, how did I do this? How did I decide that I had this warranted a workup? Well, I use joint vibration analysis on every single patient that walks in my door. And I also do something called reading bites, and we'll explain that in detail in a few moments here. These are 2 things that we can do in moments to get an idea of what's going on with the orthopedics, with every patient, young and old alike. The JVA, most of you are probably familiar with this, but basically the patient opens and closes, and those tiny little sensors there are listening for tears. It's not really a noise thing, it's more of a vibration thing. I'm not going to get into that detail, but the bottom line is there's software connected to that analog hardware, and it gives us an idea of what might be torn up in the joint. And it's a very accurate idea. And this is a guy who uses JVA and shoots MRI both. So over the years, you could tell a coherent story about. Over the years, I've had plenty of experience cross-referencing the JVA data with an MRI. I can tell you with certainty, the less deranged the joint is, the more accurate it is. It's almost 100% accurate. The more deranged the joint is, it's slightly less, that one's getting a little bit tougher. But here's another quick pearl. Probably half or more of my patients, my normal patients that walk into my general practice, have deranged joints, and yours do too. Okay, I don't care what they taught us in school. I don't care. Here's the reality. Most of us adapt. That's the reality of the situation. All right, so the patient's name was Brandon. And here's a quick video of his JVA data. And you can tell that we have some tears. This is the closure. Here's the opening. Closure, opening. Especially on the right side. The left side is not so bad, and that could be crosstalk. But the point is, pointed out to me that there's something going on. He's snapping back on the disc, likely here, and then back off before he closes again. So, now here's the good news. The good news is the JVA told me he's probably 3A, which means torn lateral pole, which I'm not too worried about torn lateral poles. I'm worried about torn medial poles. But he's getting ready to jump $20,000. And I explained to him the importance, and he went for it. and he totally appreciated the fact that I wanted to vet his joints. Now, here's some good news. The FFT setting on the JVA, I don't see a whole lot of activity above 300 hertz. If I did, I would have insisted, I wouldn't have taken the case if he didn't let me screen him. Okay, so this was kind of elective and optional, but he and I are both glad that we screened him, and you'll understand why in a few moments, or by the end of this talk. All right, so I mentioned that I was going to talk about reading bites. This is something that Dr. Mark Piper taught me years ago. So Piper's been at the bottom of the TMJ pathology funnel of hell for decades, about 3.5 decades, actually. And he's found over the years, and this man has shot over 25,000 MRIs, by the way. He's found over the years that he can oftentimes get an idea of what's going on with joint condition based upon something that he calls reading bites. So if you look on the far left here, we'll have an IEP bite. What does that mean? Incisal edge position. So the patient protrudes, lines up the midline, and look how we have clearance bilaterally on both sides. Now, the reason for that is because you have an articular eminence and you have a disc in play up here. And as things slide down the condylar head, it helps separate, get you off of back teeth. Okay, it's not just the teeth. Remember, we've got disc in play, we've got eminence shape, we've got the condition of the condylar head, it's the ligament intact, where's the disc, lateral and medial pole, both, etc. So because this is intact up here on both joints, this is part of the reason why we have separation. Don't think it's just because of this. Think outside the box. Think up here in the orthopedics and think about how the anatomy of the mandible is connected. Remember, the mandible is one big door and you have two hinges. So the IEP, we're looking for clearance. Now, this is something that we call canine edge position, the CEP position. So tooth number 11 and tooth number 22 in the US code, the two left canines, you put them edge to edge and you look on the working side, because it's a left excursive movement, you have clearance. That's a good sign. On the balancing, you have a little bit more clearance. That's a really good sign. And then we do a CEP right. So right canines touching edge to edge, a little bit of clearance on working, even more clearance on balancing. Those are all really good things. Okay, that's what I want to see. Does that mean 100% that they have beautiful joints? No, not 100%, but it sure is a whole lot more accurate than me guessing and palpating and asking about subjective symptoms. All right, so that's the ideal. Now let's look at an example of not ideal. The patient is protruding. This is one of my fly-in patients for who knows where. The patient is trying to go to incisal edge position, and look how we don't even occlude on the anteriors. All the posteriors are in play. Midline's lined up. When this patient goes off to the CEP, to the left side, he can't even occlude there. There's no separation here. Think about that upside down hillside that is the eminence. Think about the condylar head. Think about the disc, where it might be, et cetera, et cetera. And now here's the CEP right position. Notice how we're occluding on the balancing and on the working. That's not healthy. And that also, as many of us on this forum know, or on this presentation know, that also ramps up muscular activity, because if you have back teeth occluding too long in time, that is a trigger to hyperfunction muscles of mastication. All right, so that is critical to understand how to read a bite. So I put together a quick video for the audience. Let me show you guys. IEP. So if I combine reading bites clinically with all of my patients, and how long did that take me? And I was talking about it. Practically, it takes me about 8 or 9 seconds. As long as the patient understands, I just touch canine to canine, touch here, they do, touch over here, touch edge to edge, line them up. I get a quick look. Every patient I see, young and old. Now, if they're super young, it's a little bit different story. But these are kind of the things that you look for to understand if there might be some TMJ pathology going on. All right, so back to our veneer case, back to Brandon. So on the left, we've got him an MIP, and on the right, we see that he's actually occluding on the anteriors, which is a good thing. Okay, if I had an anterior open bite, that'd be another discussion, as Marcelo and I are both acutely aware of. But here, This computer keeps freezing. I apologize. So as I mentioned earlier, he and I both decided to do the neural occlusion screening, the NOS. And let me show you a quick video here. This one's not so quick, if I can get it to work. Hang on. I had trouble with this earlier. There we go. All right. Pre-op, to give you guys an appreciation. There he is at IEP. Retracted maxillary view. Retracted mandibular view. Look at that wear. Is it just because of the supererupted porcelain crown, or could it be more? So let's start with the left TMJ CBCT. Notice up here, C2, where the den sits in C1, that's also relevant in my neural occlusion screening exams. And this is just a quick preview, okay? We're looking at condylar head surface area. We're looking at the shape of the condylar head. We're looking for breaks in cortical bone. You know, we're looking at, when we look at the sagittal view, actually this is a coronal view. We're looking at lateral and medial poles. We're taking measurements there. Again, this lecture is not designed to define neural occlusion screening. I'm just running through it rapidly here. Whether or not my coronoid process is inferior to the top of the condylar head, that's relevant to growth and development. Here I am looking at C2, C1. The right TMJ CT. Look at the eminence, nice and steep. Look at the distance. Look at these measurements, lateral and medial pole. I can't see a disc here. This is a CT. Look at the condylar head surface area. Again, you're going to see me clicking on this. Why? Because I'm looking at C2 the way it sits in C1. Why? Because when people have problems, oftentimes it's C-spine referring up to lateral face. And I'm not qualified to treat that, but I am qualified to help them identify that problem. And of course, when I have CTs, I also screen apices. Now, here we come to the money. The MRI lets me look at soft tissue, hydrogen ions. This is a T1 MRI. We're on the left side. I'm looking to see if the cancellous bone is alive or dead. If there's fat present, this is going to be silvery white, which it is. And notice here's my disc. It's in play. Now I'm over to the right side. And as I scroll, there's my condylar head. The whole point of T1 is the fat there or not. If this was black in its entirety, I'd be worried. This is a T2. Look at all this white. I'm looking at H2O. I'm looking for inflammation. This is the left TMJ. So I'm looking for edema, which would be fluid in bone, inflammation in bone. And I'm also looking for effusion, which would be fluid in soft tissue spaces. Do I see fluid in bone? No. Do I see effusion out here in the soft tissue spaces? No. When I go to the right side, I'm on lateral pole. There's the ear. What's that? That was a little effusion. That was inflammation right there. That white streak, that doesn't belong there. It's tiny, but it's there. That's a sign of acute inflammatory response. This is a proton density scan. This lets me see the disc even better. So it lets me put a clock face so I can get a Piper classification. That's about a 10 o'clock posterior band. And as I go more medial, it's crawling up to about a 12, 12:30. So medial pole's in great shape. Right side, proton density, it's about 12 o'clock on the lateral. And where are we on the medial? We're probably around a 10, 10:30. So he's displaced on his right side. And this is a stir, which is another way to look at water. And right over here, I'm on my right side. I'm confirming that I have no effusion, no edema, and I don't. Now, as I scroll over to, that was the left side, I'm sorry. I scroll over to the right side, it re-emphasized there is my effusion, inflammation in soft tissue spaces. But I do not have edema, which would be worse in bone. If I had fluid in bone built up, that is a big negative. That is not a case that I would ever want to alter an occlusion at that moment in time. I'd want to track that case. Now, here we are at different positions. Is the disc in play between the bones? Yes, it is on both sides. So the patient does reduce. Even though they're torn in their normal MIP position, they are reducing up underneath the discs. That's a positive thing. So this MRI told Brandon and I that you've got a little bit of inflammation on your right TMJ, but you're asymptomatic. It's small. It's on the lateral pole. I explained to him the difference between lateral and medial pole and the relevance to the occlusion. And he and I decided to go ahead and do the veneers. Okay. However, this wasn't the extent of the NOS screening. There was more involved. All right. Now, this is another thing. I need to go back to the MRI imaging. I'm right here. I'm looking at ramus height. that's linked to growth and development. 65 to 75 millimeters from the top of the, from this point to that point, that's what it should be if the patient's fully grown. Many times I'll be doing a screening on someone and it'll be about 50 millimeters. That patient had a growth defect, an osteochondral growth defect, and that could be part of their problem. Then the biometrics come into play. We're looking at mastication analysis. That was the left side first and the right side. It's basically giving me an idea of how the movements of the mandible relate to the muscle. And here's a resting EMG. I'm putting numbers. His temporalis muscles are a little bit hyperactive. The rest of them look pretty good. And here he is clenching together on all his back teeth. And I was initially, let's see if I remember right, I looked for silent periods, didn't see any. Anterior cotton clench. Not a bad reading. Things are decent. Okay, and then this is a Loretta decompression test. Basically, the patient's just clenching together. And here I was looking for silent periods. There were none. Silent periods are often coincident with TMD problems. Patient's clenching. Bilateral temporalis masters and digastric. So closing muscles and opening. Here they're on their right posterior. Clenching on a right cotton roll. The left is suspended. These numbers look decent. These look relatively normal. Now he's got a left posterior cotton roll in place. So his right joint isn't as compressed. And now here on this last one, we had the patient clench on both the right and left posteriors, kind of hanging 10. The anteriors aren't occluding. And these numbers are not out of line. So I did not consider those a problem. Here's a patient opening, swallowing, closing. Pretty healthy numbers. Digastric should be active when you're opening. Those are opening muscles, secondary opening. And here's some closing muscles. And the gastric should not be overly working. Here's a JVA with a GT, with a jaw tracking combined. Now my numbers are a little bit different. Bottom line, notice this also, I'm kind of moving off to the right a little bit. And also here with my velocity tracings and all this, I'm moving off to the right. And which was the more deranged joint? The right side. We saw that in MRI. And then we combine T-scan data for some time with EMG. And you'll notice when you look at this graph, if you know what you're looking for, that kite, that center of force icon should be moving straight up to the anterior, but he's kind of lagging on the back here. Now, that's not necessarily a good thing, but this is an asymptomatic patient. Does that mean I'm going to alter his bite? Well, I look over here at the EMG readings. The contralateral temporalis is shut down, so I don't even alter his bite. It's not just about force and timing. And now when this patient makes a left excursive movement, the right, look how quiet that right temporalis is, below 8 microvolts. Even though this patient has a slew of posterior interferences and mid-course corrections and a long disclusion time, in this patient, I don't touch this one. I see long disclusion times often that I never alter. Just because they have, it doesn't mean you chase it. Years ago, I kind of did. And over the years, I realized there's times where I touch and there's times where I don't. Now, that's not saying it's not important. It's very important in the right situation. But these are examples of what we do in neural occlusion screening. And this was a very rapid run through. And it's not entirely complete, but it gives you a great idea of what I do when I do this. So at the end of the day, what I found that was most relevant was that he had a small lateral pole effusion on the right side. And as I mentioned earlier, regardless of that, we decided to proceed with treatment. And I found that per the NOS, he had bilaterally relatively stable and adapted TMJs. They were Piper 3As on the left and Piper 3A on the right. He was a borderline 4A on the right. Okay, we proceeded with his veneer treatment after we made him own his problems. Now, his biggest problem wasn't that big, but he had a small effusion. Effusion, again, is fluid/inflammation in the soft tissue area. Now, this is a very fast video that I thought was worth showing so you can hear from Brandon himself.
I had some chipped teeth from a football accident when I was, about 10 years old, and the cap or crown that they put on it was, out of place, too big for my mouth, and really just didn't look all that good. So it caused some issues with a couple other teeth, and I just needed to get it fixed. I'm exactly 1 week after having veneers put on, and it's been a great experience. I haven't had any issues. It's just been learning to smile bigger is the only thing that I've had to have any issues with. You go from not smiling at all to everybody wants to see you smile and you feel confident, and it's just been a blessing. So I'm super excited to get it done, and Dr. Nick's knocked it out.
So there he is, finished that same day, and happy guy. And guess what else we decided to do for him, or not do for him? No splints. Okay, because he has relatively stable and adapted joints bilaterally. Most dental practitioners, after doing porcelain veneers, will slap splints in to protect the bite, so to speak. He didn't need it. All right, so what essential tools do we use to vet his orthopedic condition? The MRI and the CT. And very briefly, I will show you guys, most of you are probably familiar with this, but I'm looking at calcium here. I'm looking at hydrogen there. And with the CT, you can only see spacing. With the MRI, you can actually see the disc. Look out here, that little black squiggly S thing. There's the soft tissue cartilage. Look here, displaced, you're on retrodiscal tissues. Look here, partially displaced. So if you're just looking at CT, you can't know that. All right, so it's a huge, huge information tool for all of us when we get used to this. All right, so there's a different patient. This is not his effusion, but I want to demonstrate for the audience a quick look at someone's effusion, inflammation in spaces. This was a T2 image of a different patient. Now this patient had Brandon had an effusion that was that large, I would not have proceeded with this case. He had a tiny one that was about out here on the lateral pole. So again, the CNO is all about diagnoses, and these are examples of things that we find in patients when we do the neuro-occlusion screening with them. Now, again, this one was for more for a biomechanical normal dental fix, but when the TMD patients come, these are examples of things that we're doing and looking for and trying to derive on a differential. Using objective metrics, of course. And I'm coming close to the end now. Bottom line is we have 2/3 of the occlusion, the joint. I want that pearl to sink home. And a very quick story. I want to underline the importance of the T-scan, the EMG, because I had mentioned earlier, like Brandon didn't necessarily need an occlusal change. This patient was symptomatic. And I want the audience to see, look at these little spikes on the EMG. This is a left excursive movement, but on the right side, you're going to see spikes going up above 8 microvolts. See this right here? This is an occlusion I wanted to alter. Okay, this patient was symptomatic, and they were cold sensitive, and they had tension. All right, so that's FDH. That's the cold thing that I've been publishing and researching about for years. So lastly, the CNO is about a whole lot more than just occlusion and TMJ. We are also dealing with other aspects of dental medicine, like lasers, PRF, ozone, for example. Our CNO5 just happened last January. This past January, I'm talking 2 months ago. And we actually had a live course, believe it or not. And there was about 30 people there, and 80% of the audience were specialists. 20% were general practitioners. And we had Rick Myron. I don't know if you guys have ever heard of him. He's one of the world's experts on platelet-rich fibrin. Boy, this computer is really messing with me. There's Rick Myron. He's published over 7 textbooks on the subject, start to finish himself, and co-authored or authored over 500 papers in the literature on platelet-rich fibrin and growth factors. He is on the CNO board. And this is something that everybody needs to hear about. That image there is of Dr. Mark Colonna. If you guys have ever heard of PIPS, photon-induced photoacoustic streaming, think root canal systems, think cleaning out lateral canals better, think about surgical extraction sites, think about periodontal disease. PIPS is an amazing tool that we can use via erbium lasers. And there's an example of CNO5, which, by the way, we recorded and is also on our CNO website. And I highly recommend that you guys take a look at this. If you can't make it, go ahead and attend virtually. And there's ozone. Dr. Mark Malter, who's kind of an expert at medical grade ozone, and there is relevance for everything that we do. And there's a quick picture of one of our CNO functions from years ago. And please feel free to join the CNO forum. It's free on Facebook, and we post numerous things on there. It's a great thing to look at the archives and the case studies that we throw up. And I'm almost done here. And Feel free to check out cnotmj.com for the hands-on courses and our online webinars, ADA CERP certification, CE credits for those US docs that are in the audience, and basically measured matters. And Marcelo, I'd like to apologize to everyone about that glitch with the computer.
I don't think there is any. There was not. I don't think that was a trouble. I think everybody could see, got the idea. Don't worry about that.
Yeah, oh, I'm not too worried. It's just technical difficulty. Please stand by.
Murphy's Law.
That's right. Okay, let me switch over to Marcelo. Oh, wow.
Okay.
We have about 30 people on now.
Yeah.
Okay,
And
Marcelo, you're on. Let me make you host.
Okay, so nice. Great presentation, Nick. And this one, I want to highlight the idea that basically we're talking about the occlusion and the TMJ as a foundation, right? We're talking about something that may happens to the joint gonna reflect on the occlusion. That's, for example, when you show the pictures of exclusive movements of the mandible showing the teeth, when you spot those asymmetry, you think about something wrong on the foundation, giving a reflex to the teeth, right?
Yeah.
I'm not saying that changing the teeth does not affect the joint, it does. But the bottom line is, well, we have to pay attention on orthopedics, TMJ, when we think about occlusion, because stability demands that, right? That's why you showed no splints that case, because in general practice, it's very common to build, reconstruct the architecture. I mean, the occlusion, because the TMJ is the foundation, right? You have the foundation, then you think about architecture when you're building a house. So you have a stable occlusion, or you have a stable joint, you may think about reconstruction of the occlusion, and you have all the technology to measure the neurophysiology and biomechanic to make it last longer, right? That's the point. You make patients feels better, because it's very common to them to say, my bites feels off, right? So I will share my screen right now and start to show a little bit of, like Nick's usually says, my stuff, right, Nick?
That's right.
But I must correct that. It's not only my stuff. You see the number of people there. There are a lot of people from South America. I can see the names there. I can't even cite all the names because I'm probably going to forget some. But there are a lot of people from South America. We have now people from Argentina, Brazil, and even Australia. Yes, Silvana, I saw you connecting. So thank you, guys. It's very nice to have you all here watching this, hearing Nick, and you are all invited, as Nick said, to participate in the CNO forum and share a little bit of what we do down there in South America. So it's not only my stuff, it's our stuff, right? And thanks to Dr. Dareta, who has passed down this for us over almost 3 decades, right? More than 3 decades, because only me, I'm studying under Dr. Dareta 2 decades. So, well, this is my city. For those that have never been here, I just put that photo here because, you know, it's kind of crazy, all these limitation to move from a place to the other because of lockdown and all this craziness we are all living, this pandemic. So this is still a real beautiful city. And we have here a lot of, let's say, are you all seeing my screen?
Yes.
Okay, perfect. Okay. This is a night view of my city. We have nice food. So beaches. This is my daughter and her cousin. This picture was took today. I took this picture today. Today in the morning, I was sending Nick good morning from the beach. I know you're there. are kind of cool right now, right? Okay, this is our life outside of dentistry, and now our life in dentistry. What I did want to share with these pictures is, well, we have a beautiful city and we have our courses down here, and in Buenos Aires with Dr. Rita, in Salvador with Brazil. And once this pandemic is gone, you are all invited to come here and to share with us all this environment, let's say all this knowledge about TMJ, and we can share with you also, show how we do our stuff. But now this is my mentor, Dr. Loretta, and I just select this slide because this paper was published in 1990 in 2009, current diagnosis of TMJ pathology. I think it was 2009. And imagine that this paper was accepted for publication in 2007. So we have been talking about that for a long. Loretta has published in 1999 cases with regeneration of condyles from a case from 1994. So we can have an idea how long this knowledge has been around. This is one of our groups. Here we have some of people that are in this conference. You can see me at the right, Dr. Loretta, with this fun drawing those students provided. So, well, we are talking about foundation, TMJ foundation. So these words are very clever, right? If significant orthopedic instability exists, symptoms may not be controlled. And what is interesting is that this was said by Oxon, and you can see it just here. So even him, who usually says that we should not change occlusion because of symptoms, had to admit that when orthopedic problems are present, the situation may be hard to control. But the question is, when there is an orthopedic problem? Well, every time we have a TMJ arthropathy, especially if it is in a acute or unstable situation. In an acute situation, the arthropathy gonna make the teeth not stable too, or not stable either. Sorry for my English people. They're being a long time without practicing, without traveling, without presential meeting. So my English is kind of out of shape. So let's go to real case, real patients. And here we are with this right TMJ of a patient that 2 weeks or 3 maybe, 2 weeks or 3 ago, I posted in the Seno forum. I posted the MRI, and this is the cone beam tomography. So we can see that the bone marrow has trouble because it is sclerotic. There's no bone marrow visible there. You can see the erosion on the surface of condyle. I do not know if you can see the arrow, my arrow of my mouse. If someone can give me this feedback. Okay,
yep,
perfect.
you can see it.
We
You
see
can
it.
see this erosion. You can see the bone marrow sclerosis. And we know something is not correct here, right? And these are, like Nick said, everyday patients. So this is the left side. It seems a little bit more damage than the right side, including the eminence, the fossa. And as you may remember that slide Nick presented with cone beam tomography and MRI, if sometimes you have this and don't have MRI, you have no idea if the disc is there or not, or even completely out of position. So
There's no place
this is
for
just part. This is just part of the diagnosis, but we can see something here, and we can evaluate orthopedic problems from these images. For example, the vertical aspect of this mandible and maxilla are affected by the amount of damage of the right and the left condyle and the right and the left eminence, mandibular fossa. That means the TMJ itself. So as you can see here, you have two different sizes. The right side from the condyle to the mandible angle of the right side and the left side, you can see that the left side is smaller, shorter, right? Now it makes sense since we were seeing left damage in a greater extent when compared to the right damage. So how that impacts the occlusion? As you can see, the occlusion is already a mess with a lot of stuff that was done, implants, root canals. As you can see, the incisors are already crowns, and she had these these complaints about breaking teeth all the time. So in practical terms, this is the occlusion impact of those TMJ damage. The right side has damage, the left side has damage to a greater extent. And this impacts the position of her whole mandible and as a consequence to her maxilla. And since all the diagnosis that has been done previously to rehab this patient was based on the occlusion position where she was already clenching, it keeps maintain the situation even after rehab. So that was her symptoms. Tension. She said she had some tension in the TMJ itself and the face, and this sensation of the bite is off, maladjustment. She said that her teeth was breaking frequently, especially the frontal teeth. Severe headache in a scale where 10 is hurting most. She was having 8 monthly, less 1 day, as you can read. The interesting part of the problem is that the symptoms was not that like 10-year symptoms. No, it was just from 1 year. But the problems with she had her probably her whole life, because she said, oh, I always had problem with my occlusion, with my teeth. I was always breaking. And when you see those kind of damage in the joint, you know that they are very old damage. The damage are very old. They are there for a decade or so. So for a long time, she was not having symptoms, but she was already having trouble and sequelae consequence to her occlusion and to her mandible position as a whole. And okay, during the morning, she used to wake up with this tense mouth sensation she described. And this is part of the images that I put there on CNO Forum. This is her right joint. And you can see this is a proton density imaging, I think. Let me check. Yes, we have TR and T, this long, this short, this proton density image. And you can see that the bone marrow that was supposed to be very, let's say, hyper signal is in hypo signal. It is dark. That means that what we see in the cone beam tomograph as sclerosis, in fact, is the necrosis of the bone marrow cells, and the body is replacing it with calcium. This is a process that usually follows inflammation. It may follow also removing it, resorption. This is the right side, and this is the left side. The left side, you can see the damage is at greater extent, and even the condyle is smaller than the other one, telling us that something that was going on already in the past. And this is interesting because she had an MRI from 2015, and this was her original MRI that was done by other dentists. And as you can see, from 2015 to 2017, the condition worsened a lot. The bone marrow, as you can see here, changed to this situation, to this kind of abnormality. This is necrosis from a radiological point of view. Erosion. Here we have T2 imaging. Well, during her treatment, before she arrived to me in 2000, her first appointment was 2017. So during this, between 2015 and 2017, she was looking for treatments, mostly because of her occlusion sensation of my bites off, as she used to say, and later because of pain. And when she reached that pain level, all they said to her was to take some palliative measures like thermal therapy, dry needling, and so on. And they completely ignored this damage to the joint. At her first appointment, I asked for a new MRI, and this is the bottom one you were seeing. So, as any other joint in the body, TMJ may be affected by trauma, by infection, but affected by autoimmunity, by biomechanical problem. If we were talking about hips, one leg shorter than the other may promote a biomechanical problem to the hips. But in terms of TMJ, we have the occlusion. We have circulation problem. If the patient has a claw and blocks irrigation, so you may have a bone marrow problem in the joint. If you have rheological problems of the blood, like problem with viscosity, problem with the capacity of hold oxygen, you may have problem with bone marrow. You have endocrine metabolic problems, you have tumors. So many things may promote those problems we see there in her. In our case, in my clinic, in my private practice, as in many other doctorate students, we go a little deeper in check what is the cause of that damage, because this is our daily practice. We deal with TMJ pathology. In this case, this was an infection by airway pathogens such as chlamydia pneumonia. As you can see here, this is a IgM low titer. You can see that the value, the cutoff value should be 9. She's 6.6. Theoretically, she is negative. But imagine that this cutoff point is for pneumonia. It's not for TMJ. And this means that she has been exposed. She has some IgM antibodies around her. She has some of these reactions going on. IgG, basically to the cutoff value, the same level of the cutoff value. But this is the point. Few months later, I repeat the test, and the number just jumped higher from, for example, IgG from 9 to 76. Even considering it's just IgG, this is infection active. So we don't have time to go deeper in this aspect of the presentation, because you may ask, for example, Marcelo, but this is our blood analysis. How do you prove that the bacteria is in the joints? If you want to know a little bit more about that, look for the presentations in the CNO Symposium. I talk a little bit about that there. But let's move on. What the impact of that damage is in terms of functioning? This is the impact. you can see that the masseters in green here during occlusion is basically not firing, and the right masseter is have much more trouble to fire than the left one, even considering that the left side has more damage. How could that be justified? Think that the left side is probably older, more chronic, and the right side more acute. So what happens? More painful input to the central nervous system and more muscle inhibition to the right side. Something that confirms with the liberator decompression test. She could bite a little bit stronger here, but you see when we put the cotton roll, it drops. Cotton roll to the left side, it gets a little bit better, but both sides much better. That means she does have an important compression. She compresses a joint that is already unhealthy, and the system goes crazy. You block it with the cotton rolls. There's more space. There is less painful afference to the central nervous system, and the brainstem allows the muscle to fire a little bit more. She had this 38 millimeters opening, and as you can see, the closure pathway loses velocity a lot. The opening is also hypokinetic, but the closure pathway is much more hypokinetics. That's okay, let's move on. Mastication analysis. As you can see, the right mastication is, the right side mastication is very, very thin. And this is usually related to trouble during chewing in the joint. The other side, very close to normal, very close to the ideal that is drawn out in white behind the red and the blue. What is happening here is that she has a lot of trouble to move her right condyle forward. I'm sorry. When she needs to chill at the right side, she has a lot of trouble to move the left condyle forward. So she can't make her mastication cycles go to the right properly. Besides, she cannot tolerate pressure at the right side, at the right joint. So she avoids chill to the right side. That's why she chilled to the left side. She could move the right condyle forward, but she cannot move the left one properly. Well, I started her treatment. She was using an orthotic to keep her craniomandibular orthopedic position that was defined by electronic deprogrammation. What you see in this slide right now. I'm sorry, I don't have any picture of that orthotic in place. I was looking for it and I realized I didn't have it. So the bottom line is, it is not a splint, it is an orthotic. A splint is something to hold there. For example, those that he had a patient and put a splint in order to protect the composites, the veneers, etc., are doing the splint. When you try to make the patient functions better, you are using orthotic or something that you can call orthotic if it supposedly is improving function. Anyways, that was the beginning of her treatment. Remember, she had an infection. So I also started her on antibiotics and some supplements that we don't have the time to go deeper on this aspect. But these are the results. During clenching, you can see the masseter, the right masseter, had recovered a lot. If you want to compare to the initial one, you can see 7.9 to 37.4. What that means? That means that now the joint is much healthier and can sustain pressure, compression during the clenching action. when during the nose screening, when you're doing DTR and you're talking about what's the word in English? Muscle hyperactivity. You're talking about excursive movements. You are doing right and left, and sometimes protruding the patient and looking for muscle that are fighting too much during the excursive movements. This is different. This is clenching. This green column here, this is clenching. It was supposed to be able to apply pressure. If it's not, it means there is damage or in the joint or in the teeth or in both. If you have painful teeth, you cannot clench hard. You have painful joint, you cannot clench hard. That's simple. Take a look now in her movement pattern. She can move much faster, what is something that's related to healthier joints. She opens much better. The pathway is not that better. You can see that is not the opening closing. This is opening closing 3 times. Ideally, it was supposed to be one over the other. We should look here and see basically one line only. The same for the frontal view. But these are real patient. And real patient is not always ideal, right? But the important thing here is that it's much better than it was before, as you can see here. Initial and control, you have much more range of motion, you have better velocity, and now the system is functioning better. The same to the mastication psychoanalysis. Oh, Marcelo, this mastication cycle is horrible. I agree. It's awful. It's a horrible frontal view and every other view mastication analysis of the right side. But take a look. It was much worse at the beginning. At the beginning, the patient could even move the mandible to the right side to chew. And now she can move. But these more thicker, let's say thicker lines, it should be a very thin line, like the blue one here, the opening phase. It's very thick. It means trouble. It means trouble. Oh, Marcelo, but this is the control. Yes, this is the control. It means trouble. It means you have to keep an eye on it. And you have to make the patient on their problem. Like Nick used to say, Dr. Rita likes to say that everything we say before to the patient is diagnosis. Everything we say after is excuse. So we have to make the patient on their problem. That means you have this information, you tell the patient, okay, you are much better, but still small problems there. I can rehab you, I can deal with your teeth problem, your occlusion problem, but you must have in mind that this is gonna be a work in progress. You are better, you are feeling better, have no symptoms anymore, but you still have some small damage there that every now and then may just have a reagudization, a flare up. You have to stay aware. And once the patient understands that, you can move on. The left side, a little bit off, but compared to the beginning, very similar. Not exactly better, even a little bit worse, but this is the reward. And that was what was achievable with this patient. But guess what? 2018 MRI, and the bone marrow that was all black in the proton density imaging is now recovering the medullary signal in the MRI. It's not yet perfect, and the mastication psychoanalysis tells us the same. It's not perfect yet, but it is progressing. That means it's reversing. The left side, not that black hyper signal of the bone marrow anymore. Much better. The disc was not able to recover, too damaged. So we finally start to plan her rehab. in terms of occlusion. The space you are seeing here is the space of the orthotic. So we have to keep that maxilla-mandibular relation there to that patient, because that orthopedic relation or relationship, better saying, or relation, sorry for my English. So this 3D position between the mandible and in relation to the maxilla has to stay there. So now I can reconstruct the teeth in that situation. We can plan the occlusion. And we did this with compositive. I think I pronounced it correctly. And I did that with Dr. Giovanna, who is also present in this conference. You may say hi, Giovanna, to everybody. The planning, the printed version, and bring that to the patient. Change the patient's smile, change the patient occlusion, but based in all we studied in terms of TMJ, stability, and now it's cosmetics. And this was the end result. And she was pretty happy, no pain, but you can see there's still an orthotic at the bottom here. Very, very small compared to the original one, because most of the space that we had was incorporated in the size of the teeth. That means we recovered the teeth, taking out the height of the orthotic. And why the orthotic is still there? Because we are now working on her lower arch. Remember, there are implants, there are teeth with a lot of damage. So we did it first, the upper one and the lower one is a work in progress. And those biometric data you saw of the control phase was already in this situation. And we did this 2 or 3 weeks ago, this rehab process. And that's why I posted there in the same forum. I hope you have enjoyed, and that was the case. I'm back to I'm not sure if the screen stopped sharing. It seems it has. I hope you have enjoyed. I apologize for my pronunciation, because there has been a long time without practicing. Maybe the next one they're gonna be a little bit better. But that's the idea. This is our daily cases. The reason we had to work on her occlusion only now, because you saw before and after, but there was many things going on in the time frame between those initial and control pictures you saw in presentation. It was tough to get her out of symptoms, was tough to get her stable, was tough to get her on rehab. And now I asked another MRI. As soon as this MRI arrives, I'm gonna post there in our forum. And I hope we still progressing. So what do you think, Nick? Do you enjoy it?
Oh yeah, it's awesome. I will have this edited by tomorrow and on the CNO forum, which all are invited to join. It's free. And also on the YouTube channel, on the Dr. Nick DDS YouTube channel. Just type in DRNICK DDS on YouTube. It'll be within 24 hours, edited and up. So if you want to spread it around, spread it around. And I'm sure we'll do more of these in the future. Marcelo, thank you. And everyone,
Thank you.
Thank you all for coming.
I see that almost everybody's still there, so I must assume we
did all
achieved
right.
our goals.
All right. Guys, everyone, thank you. Thank you for being here.
Thank you. Thank everybody.
Take care.
Bye-bye. Have a great Saturday and Sunday.
What's left of it, right? That's right.
For sure.
Have fun at the beach, Marcelo.
Cheers.
Goodbye, everybody.
Thank you.